Dr. Wasim. Thank you, Vinita. Thank you for inviting me. And this is something which all of us, this is a good meeting, and I feel more and more interested towards now head and neck cancer. Because the data are interesting, and I think let's see in the next 15 to 20 minutes, as a medical oncologist, what I really how I look at a locally advanced disease, and my talk will be specifically on the inoperable locally advanced disease. So that is where I will be keeping my talk restricted to. So you have, and we this is the meta-analysis all of us speak about when we speak of head and neck cancer, especially on the chemotherapy, the which part, which schedule, when to give chemotherapy, and we have this updates coming up every 4 to 5, 6 years. The last big publication was some 10 years back, but we had an update maybe 4 years back. And this is a big data of many thousands of patients. And this data, what does it show? This is again update which was in 2016. Sorry, it's not 2106. In 2016, which was in Annals of Oncology, which came as abstract. We just added 15 more studies and came to the same conclusion what the initial publication was by Pignon. And this was what it is, that if you look at it, the patients who take concomitant chemotherapy do have a benefit over radiotherapy alone, and the benefit was approximately absolute benefit at that point of time in the publication was some 6-7%, which has come down to around 4 to 5% at this point of time. And if you look at it, the induction chemotherapy did not play a role. It was a small marginal benefit, which was statistically not significant. We'll talk about it in a bit. And that is what it is. The polychemotherapy and the cisplatin monotherapy both had a benefit. Just to tell you what was spoken just before, this trial, the single agent cisplatin, every single trial with concomitant radiotherapy showed a benefit, except for one study where the cisplatin dose was very low, below 150, I think so 120. So that's where the benefit was not seen. So this gives a big idea that whenever a weekly or a 3 weekly cisplatin is given, at least the 200 milligram per meter square dose during the duration of radiotherapy is something what all medical oncologists should vouch for, because there is good data to tell that it is a dose dependent. You would optimally try to reach 300, but 200 is something which is the cutoff. Is there a benefit of additional beyond 200? There is data which is little bit controversial. We can go on speaking about it, but definitely a dose lower than that, it is not going to give that benefit. That's one take home message. If you look at it, there is a benefit of overall survival and event-free survival and loco-regional survival if given concomitant, and the induction chemotherapy did not land up with that amount of benefit. All of us know the local failure is lesser with the concomitant one, and the distant failure is more with the induction chemotherapy. And this is no different with different chemotherapy protocols. So with that background, I go on to the first neoadjuvant, and the second part, which will be a major one, will be which is the best concomitant therapy to be used. In the neoadjuvant, in the operable setting, there has been few studies. Most of them were not have looked at it to look at to whether they can conserve the organs. That is what they have achieved to. Whether if you give neoadjuvant chemotherapy in operable oral cancer, can we achieve a survival benefit? Those trials were not big enough to address this question, but there has been a marginal benefit which has been statistically insignificant. The only thing inoperable what I can do of is with the data, probably organ preservation can be achieved. There is data that mandibular resection can be saved, and lot of patients, around 20% in some data, have shown that you can preserve mandibles in a borderline mandible involvement provided you give neoadjuvant. In the inoperable setting is the question which we are going to address. And these are the two studies which are all normally spoken of in induction chemotherapy, the TAX 323 and the TAX 324. The only take home message is TPF is superior to the cisplatin 5FU. The second take home message is a docetaxel is 75 per meter square with a cisplatin reduced to 75, and the 5FU 750 is the way to go ahead. Do not attempt to go for 100 milligram of cisplatin and 1000 milligram of 5FU, because that is going to be very toxic with docetaxel. And if the reduced dose of cisplatin 5FU, it was seen that the toxicity was okay, tolerable, and it was much better actually with this cisplatin 5FU doublet. So that is the take home thing, that TPF is the standard if someone is going to think of neoadjuvant, and the dose should be a reduced dose of cisplatin 5-FU, and docetaxel should be 75 milligram per meter square. The 3-3 use 4 cycles, 3-4 use 3 cycles. What is the optimum cycles? The optimum what people have used is from 2-4. You have to choose anything between this 2-4, never exceed 4, because none of the trials in neoadjuvant setting have exceeded 4 cycles. This is the 5 studies which I could pick up, which are directly compared CTRT versus induction plus CTRT. There have been 2 trials which have been, lot of the things have been talked about, is the paradigm trial and the decide trial. These 2 trials, to be fair to them and to be fair to, and to be not to be unfair to the neoadjuvant chemotherapy, lacked the power. That did not go ahead and complete their scheduled recruitment. And one of the trials recruited 70% patients, and one of the trial concluded with 83% patients. So with that underpowered, it did not show that chemotherapy in the neoadjuvant setting was beneficial. But for the GSTT trial, which is a Spanish trial, which looked at the 2-2 randomization, which looked at TPF versus as an induction chemotherapy versus versus other agents which were only chemoradiotherapy, but here as a radiosensitizer, they use cisplatin and 5-FU, or they use cetuximab. But look at the trials, and this is one of the bigger trials of 400 odd patients, which at stage 3, stage 4. This did a PFS of 30 versus 18 months in terms of PFS, which was statistically significant for the neoadjuvant. And the increase in median OS was also there, and that was around hazards of 0.74. So my point of this is, the last thing about neoadjuvant chemotherapy has not been answered. There is going to be a space for neoadjuvant chemotherapy. It cannot be used on a routine setting, but if used adequately, I think in the right patients, you know that neoadjuvant chemotherapy has a role today. Who is the big question today? The who is to be something where we can be thinking of something like organ preservation. That is the normal one indication what I think of. Some areas neoadjuvant chemotherapy do help in pre-operative also. What? That is very, very clear. It has to be a triplet TPF. That is the best possible regimen that you need to go for neoadjuvant. How much? How much is 2-4 cycles? Don't exceed 4 cycles. 2 is the minimum. 3 could be optimum, but that answer of exact number of cycles is still open. So with the meta-analysis, we know radiotherapy alone is inferior to concurrent chemoradiotherapy or RT plus biologicals. Even cetuximab plus radiotherapy has shown to be superior. So which is the best partner is the optimal question. Yeah, the question that comes to all of us mind. The contenders: cisplatin high and low dose, carboplatin single or combo, cetuximab, nimotuzumab, biologicals, and chemotherapy. So look at this: cisplatin 3 weekly versus weekly. I looked at the head and neck cancers in the Veterans Affairs of Oncology files, and this was a retrospective data. And they looked at high dose cisplatin 2200 versus low dose of 701. The low dose was 70 milligram per meter square, and high dose was 100 milligram per meter square. And what they looked at is, if the curves were matched for survival, there was no difference in the high dose and low dose. This is what it is in a non-randomized retrospective, but big data which cannot be just looked after. And this is the conclusion, that high dose, low dose, both are equal. Toxicities are different. This should be taken in context with this trial of JCOG, which is adjuvant data. Mind you, this is adjuvant data purely, and Tata data was predominantly adjuvant, but there was a minor patients who were also taken in this data for Tata Memorial. We looked at weekly versus 3 weekly, which had the concurrent use as a radical intent. This data was somehow strikingly different. The full text of JCOG, the Japanese trial, is, I think, not yet out. We like to see that. And if you look at it, there is a difference in the loco relapse. The weekly did better in the Japanese trial, while the 3 weekly did better in the Indian data. And the second point is, India, Tata, which has been leading the trials in head and neck for us, has always used weekly cisplatin dose across their studies at 30 milligram per meter square. That is a little bit different from what the Japanese have used at 40 per meter square. Is 30 per meter square 7 doses, you cross the 210 mark, mind you. But if you don't touch the 200, are we doing justice, is something we need to ask. That's something which I need the panel to answer at some point of time. Chemotherapy, cisplatin or carboplatin, for those who are not eligible for cisplatin, which is the best agent? The only thing that I could find in a bigger, you won't find a randomized trial. This is the data which has come again from the retrospective analysis. Whenever carboplatin is used, 60 to 70% of the carboplatin used along with radiotherapy has been used with some other agent. It can be taxane platinum or carboplatin 5-FU or a carboplatin cetuximab. While cisplatin, majorly 90% has been used as a single agent. This is one of the major differences we wanted to highlight. Carboplatin data is majorly with the couplet. Cisplatin data is majorly as a single agent. And this trial shows the cisplatin and RT versus carbo RT, there is no difference. Cisplatin RT versus RT, there is a statistical significant difference towards the concomitant. Carbo RT versus RT, there is a benefit for the carboplatin arm. Now let's come to the big topic of biologicals. Which one? Look at cetuximab. I will go into 2 or 3 trials, not into all of it. The meta-analysis I'm going to pull out, which was published last year. In the OS and the PFS, the cetuximab somehow lost out to platinum. In the human papillomavirus positive subgroup also, it lost out. Look at the cetuximab plus cisplatin versus cisplatin in the definite concurrent radiotherapy in head and neck squamous cell in the analysis of Veterans Health Affair. The same thing, cisplatin cetuximab retrospective, majorly were oropharynx and hypopharynx or larynx. Cisplatin was inferior to cetuximab irrespective of all sites and the multiple subsites. The high dose cisplatin was superior and also the low dose cisplatin was superior. Look at the in elderly, in squamous cell, definite RTCT. And if you look at it, the yellow is the concurrent radiochemotherapy, which is the chemotherapy. The dotted blue bold is a cetuximab and radiotherapy, which normally is much inferior and actually little bit maybe or same as radiotherapy. And if you look at a further thing, which was for elderly, 65 years old, oropharyngeal cancer, cisplatin appeared to be the best agent, even in elderly. So in a fit elderly, do not just think of excluding cisplatin. Still, this is the drug of choice. And carboplatin could be the second, and cetuximab fares a low third. Now, 2 last studies before I end. The RTOG0522. This is the data which really opened the things, and this was the data for cisplatin, cetuximab, RT versus the RT and cisplatin. The most important point that needs to be pointed out is the P16 expression in oropharyngeal tumor, which was higher around 35% in this study. This trial showed there was no benefit of the addition of cetuximab to the chemotherapy and radiotherapy combination. And the most important problem could have been because this drug did not show a benefit in the oropharynx P16 positive cases. To add to this, go to the data from Tata Memorial Kumar et al., which I think Vijay was the lead author, and a randomized phase 3 trial comparing nimutumab plus cisplatin chemoradiotherapy versus cisplatin, same exact thing what they looked at, but looked at the HPV positivity, it was much lower than what the RTOG trial had. And this trial showed a significant 2-year PFS benefit towards the nimutumab arm, but the OS was not statistically significant at this point of time. So this is what the thing should be, that we have a combination that could be showing in the PFS to be superior in addition to adding cisplatin radiotherapy to nimutumab, but the OS data is still not mature. The primary endpoint was PFS, the secondary endpoint was OS. I think whether it was powered to answer this OS data, I'm not sure. We have the authors in the panel, probably they can take up this question, but what I get to know, this benefit they have looked at and they have written also that this could be a contender, and still cisplatin single agent with chemotherapy, with radiotherapy, even as per the authors of this paper, was to be considered a standard of care. Do we need to change over to add a biological to chemoradiotherapy? I think it's a good question which the panel will take it up. So to conclude, concurrent chemoradiotherapy remains the standard of care. That's the point number one, the take-home message which I want to take. Induction chemotherapy, there is data that is evolving. I think there is data because the trials of induction chemotherapy unluckily has not been powered to look at it. Then the trials which were powered to did not recruit as it should have recruited to. Or sometimes the radiotherapy arm was chosen and had better prognostic criteria. So with lot of lacunae, whatever said and done, today we do not have a consistent advantage of induction chemotherapy to be given. We just cannot discount in induction chemotherapy. All of us have done it. We'll be going on doing here. How much cycle is 2 to 4 cycles? But cisplatin as a concurrent agent takes the cake. And it should be an intensity of at least 200. If you can touch 300, lovely. But one trial we showed an inferior dose. Did you lose me?
Yeah, you are audible.
Yeah. So was I in the conclusion slide?
Yes.
Yeah.
Dr. Wasim?
Yeah,
was it the conclusion slide when you lost me?
Yes.
Yeah. This is the slide when we lost.
Okay. So concurrent chemoradiotherapy is the standard of care. Induction chemotherapy has to be individualized. There were problems with the trials. I think the panel will discuss that, I hope. But induction chemotherapy cannot be written off. It has to be individualized. Cisplatin single agent appears to take the cake. Dose intensity is very important. Yeah. Nimotuzumab with cisplatin, low dose with radiotherapy in a human papillomavirus negative is something that I'm sorry, I'm losing the connection, but I'm the last part of it. I'm sorry. Yeah, I just want to finish off this quickly, and this is the last point of it. I'm sorry. Age, performance status, audiometry, because there are patients who will have hearing problems, comorbidity to be considered before you choose the right appropriate biological, or it's a carboplatin or it's a cisplatin. My only thing which I think the panel will answer, should we be mandating human papillomavirus testing in the patients whom we want to choose a concurrent agent and not use biologicals when we find it's HPV positive? Is it open question or is it answered? I think that is something which more data will tell us. But what the data is, biological somehow is not doing well with the human papillomavirus positive patients. With that, I thank all of you for a patient list. Few of the questions that has been in a dilemma. Thank you.
Presentation and very wonderful presentation. And I think always like that, there's always debate about this higher and paradigm. This is not a debate, but thank you, Dr. Sahoo, again. And now we have a polling question. Please, can you run the polling question now? Yeah, so the polling question is very important question, adding nimotuzumab to chemoradiation. I think Dr. T.P Sahoo has described it beautifully. Adding nimotuzumab to chemoradiation in locally advanced squamous cell head and neck cancer improves outcomes and can be considered as standard of care. Yes or no or not sure, you have to answer that. You can share the poll. Can you share? I think yes, 50% have answered yes. So lot of percent, I think a lot of doctors are using, a lot of oncologists are using nimotuzumab, and 27% have used no, they are not using, and 20% are not sure. So I think we'll see, and we'll go ahead from here and see what changes for